So there must be something in the water in Southampton, because here we go again. We have some more guest speakers from the University of Southampton, for which we're very grateful indeed. So we have now Professor George Lewis and Claire McDermott, Dr. Claire McDermott, who are going to, well, in fact Claire I think is going to do most of the talking, but no doubt they'll share the questions. Is going to talk to us about a scoping exercise they've done about provision in the NHS for patients severely affected, continuing with our current theme. So I'm going to hand over to Claire, who will give you the results of that work.
Hi, I'm delighted to be here today to share with you the findings of this scoping exercise that we carried out last year to find out what's available across the country for adults who are severely affected by chronic fatigue syndrome, ME. This slide shows the members of the research team. As was just mentioned, I'm joined by Professor George Lewis, who is a co-author and also my supervisor. And the study was conducted as part of a PhD fellowship for myself, funded by the National Institute of Health Research, specifically to look at the topic of patients severely affected by CFS-ME. I came into this topic through my own personal experience. I was very severely affected myself in my teens and my 20s, so many of the issues we've been talking about today resonate with my own personal experience. I was very lucky in regaining my health, and when I was well enough to go back to work, I went into medical research and have worked on a number of different illnesses. But in ME research, I've been very fortunate to work on a range of studies, including some of the very early work on gene expression profiling with Dr. Jonathan Kerr, which some of you may be familiar with, other work on immune function. And it was fantastic to hear Hugh's talk this morning about how much has moved forward in the last decade in our understanding. That was fantastic to hear. At the same time, as Sonia pointed out, we don't currently have an effective pharmaceutical treatment for the illness. So as a researcher, I'm really interested to know how we can help people better with what we do have to hand at this current time. So other aspects of my research have involved talking to patients with experiences of getting better from the illness to find out what they found most helpful and what worked for them or didn't work for them. Finding out patients' hopes and expectations of specialist services. We've talked about that around the small table discussions earlier. And their experiences with specialist services. So this study fits within that area of looking at service provision. But I'm delighted that we are here today specifically to talk about severely affected, because this is the patient group that is so often left out, the group that so often fall off the radar. So I want to say a particular welcome to everybody listening at home, not just to everybody in the room here now, but to all of you listening at home who are too ill to attend, because actually, in many ways, you are the most important people here. You're here electronically rather than in person, because that's what today is all about, to see how we might collaborate, work together, find ideas that we might be able to make the situation a little bit better. So, this study was a very collaborative study. We were helped by two charities. Mary Jane Willows is here in the audience from the Association of Young People with ME. We were also helped by the Dorset ME Support Group, who are my own local support group, who were fantastic support to me when I was at my most ill. These charities helped us in planning the study. The study was also supported by the British Association of CFS-ME Services, and they were invaluable in helping us work out who we needed to contact and how to contact them. The study was published by BMJ Open this year, and AIM did a fantastic job in helping us with the press releases and the media interviews around that, because it got quite a lot of media interest. So, I will move on to telling you what we did and what we found. We contacted all 49 specialist NHS CFSME services in England, and these were the adult services. We got replies back from everybody, which was great because it means we have very full data. And we found that of these services, 55% did provide a service for severely affected patients, and that's the blue section in that pie chart. However, 33% were not providing anything at all for housebound patients. We asked respondents about the barriers to provision of care, and perhaps unsurprisingly, the biggest barrier of care that came up to provision of care that came up was funding. So many were not funded to do home visits, and obviously if somebody is too ill to travel, they need to be visited at home. I know in our small table discussion that came up as a really crucial point. A few studies felt that they were borderline. 3 reported that they provided help very occasionally when possible, within limits of funding. 3 services reported that they provided a regular service, but could only do so by telephone or email. They were not funded to go out and see people at home. So to summarise the services that were providing help to severely affected patients, there was 1 NHS inpatient unit. Now I'm aware that there are other inpatient or residential places across the country, but this study was specifically looking at NHS services. 26 services were providing home visits, and 3, as I just mentioned, were providing regular help, but couldn't visit patients at home. So there were 30 services involved in providing care. And these were the services that we went on and asked questions about their care pathway, their diagnostic pathway, and what they were offering to patients. So the first question we asked was about diagnostic criteria. The vast majority of services were using the Centres for Disease Control, VACUDA criteria. That's 77%. 10 services were using both the CDC criteria and the NICE criteria, and for anybody not familiar with the distinction between those, one of the key differences is that the NICE criteria allow diagnosis after only 4 months of illness, whereas the CDC criteria requires 6 months of illness. 5 services were using the NICE criteria only. 3 services were offering no diagnostic service and only accepted referrals for patients with prior diagnosis. So once a patient was diagnosed, what were services offering? Now, all of the services reported that they were offering a package of care. There was no service that offered one single treatment approach. Sonia mentioned the difficulties we have, that the fact there is so little research evidence on what works or doesn't work for this group. And that within that context of so little information, it perhaps makes sense that services were offering a portfolio of different approaches for people to choose from or put together as a package. 93% of services offered within that package activity management. Now, if you look at the list, you can see that some of these titles of treatment approaches perhaps overlap a little. Perhaps activity management, lifestyle management, you might say that there's quite a lot of overlap. And we're interested to know the different names that services used for their treatment approach, which didn't always describe something massively different, but was how they were titling it. 83% of services were offering CBT or elements of CBT. A frequent comment on the questionnaires was that, particularly with working with very severely disabled and severely affected patients, they are so vulnerable, they have so little energy, the cognitive difficulties are so severe that whatever you're using has to be adapted considerably if it's going to fit that patient's needs. So a number of services commented that they used elements of CBT rather than a formal CBT package. 80% were using graded activity. We're interested to know that mindfulness, this is a relatively new treatment approach. 73% of services were offering that. For anybody that isn't familiar, it's an approach around relaxing the body and stilling the mind. We discussed pacing earlier, and 57% of services included pacing within their package, not as a standalone therapy, but as a component. This gives you the details. If anybody is interested in reading the full paper, it is online, so it is freely available, and you can read the detail there. So who is providing it? All the services reported that they had a multidisciplinary team. They had more than one different kind of health professional on the team. 90% of services had a doctor, either a consultant or a GP with special interests. In terms of therapists, the most commonly reported was occupational therapy. I know we've got some OTs in the audience who are smiling at me at this moment. Other therapists, and you can read the figures on the slide, are physios, clinical psychologists, nurses, counsellors. A few services actually had a dietitian on the team. We've talked this morning about the importance of nutrition and making sure that people actually have adequate nutrition. The services which didn't have a dietitian often reported that they had access to referral elsewhere if a patient needed it. I personally was very interested to note that 3 services had peer specialists in the team, individuals with their own experience of getting better from the illness, who were working alongside the health professionals to give encouragement and support to current patients. We were curious to know how many patients were being seen across the country. The average caseload per service was 16 patients, but within that figure there was a huge range between only 3 patients and 90, which is a big, big range. So we're quite curious about this, so we contacted services to explore it a bit more. And there seemed to be 2 reasons for this. In some cases, it related to services being set up specifically with the remit of focusing on the more severely affected end of the spectrum, but sometimes it related to discharge policy. Some services offered, if you like, a package of home visits after which a patient was discharged. Other services allowed patients to stay on the books, sometimes as long as they needed or as long as they wanted, for support, perhaps by telephone or occasional visits. But adding the total number of severely affected patients up in terms of all the caseloads, the numbers combined was 408. Now, how does this compare with the numbers of patients out there in the community? I can see some shaking heads in the audience. By any estimate of figures, this is a minority. It has to be a minority. We don't have any prevalent studies on severe CFSME, and I would love to see those happening. I think that would be a really, really valuable thing. If anybody knows of any prevalence data, prevalence being how many cases there are out there, please do let me know, because we've searched and searched. The closest we could find to it, in terms of work done in the community, was a very small study done in Dorset in 2004, in which the Dorset ME Support Group and the Dorset CFSME Service joined forces to contact all the patients on both of their books. And just out of that survey alone, they found 48 patients within Dorset who were severely affected, and severely affected according to Fukuda criteria, and checked that they definitely had the illness, and they were definitely severely affected, checked by an experienced doctor. But of course we don't know how many the Dorset study didn't identify. It might have been a lot higher than that, we just don't know. We've talked this morning about 25% being a possible figure, but we truly don't know. But by any estimates, this study suggests that the majority of patients out there who are severely affected are not getting specialist care. So to conclude, we concluded that there are serious inequities of access to specialist care for this patient group, who are, of course, the patients who are most in need. They are the most disabled. In 2012, Simon Collin and his team found that 8% of primary care trusts, which are obviously now become clinical commissioning groups, don't have a CFSME service at all, as many of you will be aware. Our study found that a third of existing services don't treat severely affected patients, primarily due to lack of funding. and a further 12% offer only minimal or occasional help. And if you add those figures together, it suggests that over half of severely affected adults with CFSME in England lack access to local face-to-face specialist care. And I feel, and I suspect there are many in this room that would agree, that to have the choice of specialist care, if that's what you would like, it's something that all severely affected patients should have. So, thank you very much to everybody who took part in the study, and to all of you here today. I think it's great that we're here to meet, to talk about how we might move things forward, to see if perhaps in 10 years' time the situation might be a little better. I really, truly do hope so. So thank you.